Well, hello, good evening, everyone. Thank you for being here today. It's our pleasure to bring you this interactive forum for cases from the community, where investigators will discuss available research guiding the care of patients with prostate cancer. This is part 2 of a 3-part CME symposium that is held here in conjunction with GU ASCO. You can see our faculty will run through everybody's histories here, bios here in a second. So immediately to my right, of course, we have Dr. Fizazi from Gustave Roussy in Paris. I think we've all gotten used to seeing him on the podium many times over the years. He's head of service and a full professor and, of course, a key opinion leader in prostate cancer. To his right, we have Emmanuel Antonarakis, the Clark Endowed Professor of Medicine, Division of Hematology, Oncology, and Transplantation at the University of Minnesota. To his right, we have Dr. Matthew Smith, the Claire and John Bertucci Endowed Chair in Genitourinary Cancers and Professor of Medicine at Harvard Medical School, Director of the Genitourinary Malignancies Program, Massachusetts General Hospital Cancer Center in Boston. And then, of course, last but not least, Dr. Maha Hussain, the Genevieve Touton Professor of Medicine, Division of Hematology Oncology, and Deputy Director of the Robert H. Lurie Comprehensive Cancer Center at Northwestern Feinberg School of Medicine in Chicago, Illinois. And I'm Alan Bryce from the Mayo Clinic in Phoenix, Arizona. Commercial support for this activity is supported by educational grants from Astellas and Pfizer, AstraZeneca, Bayer, Exelixis, Janssen, and administered by Janssen Scientific Affairs, LLC, Lilly, Merck, and Sanofi. We'll see everybody's disclosures here very briefly. All right, so now we will get into our program. So the agenda tonight, we have multiple modules. The first one will look at management approaches for non-metastatic prostate cancer, then optimizing the care of patients with metastatic hormone-sensitive prostate cancer, then current therapeutic options for newly diagnosed mCRPC, and then best practices for management of mCRPC for patients harboring HRR gene alterations. Dr. Fizazi will be presenting at the end as well. The cases that were sent in are pre-recorded videos by community oncologists. So this is the panel of physicians from across the country who have contributed the cases. You'll be seeing them, each of them throughout the night. All medical oncologists, with the exception of Dr. Morris, who is a urologic oncologist and an advanced prostate cancer practice. And then, of course, Dr. Neil Love, who has something to do with research to practice, I guess. So we'll start in on Module 1. We're going to talk about management approaches for patients with non-metastatic prostate cancer. We'll do the first video and then get into some questions.
Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to our real-world case library, tonight focusing on cases of prostate cancer. The first case is presented by Dr. Priya Rudolph, a 72-year-old man treated 7 years ago with external beam radiation therapy for a Gleason 8 primary lesion, but since then has received ADT and other novel therapies for persistent PSA elevations.
He has had multiple scans along the way since 2018, and interestingly, throughout all these many years, he only has one area of uptake in the left side of his prostate. There is no activity elsewhere. Would love to know if investigators have used anything locally after external beam radiation therapy to the prostate, such as cryotherapy or radiofrequency ablation or SBRT or proton therapy, which we now have, because that is really the only site of disease. Given his low level of tumor burden, I would love to know if intermittent androgen deprivation would be something people would use, and more importantly, how would you actually do that? How many months off? How many months on? What do we do with the darolutamide? Do we keep that going? Could that be intermittent? Anything that can alleviate his side effects.
So as a follow-up to this interesting case, what forms of local therapy, if any, would you consider for this patient?
Okay, so perhaps I'll ask Dr. Smith if you want to start us on that. What would you consider as options for local therapy in a patient previously radiated and now with rising PSA and this spot on a PET scan?
Yeah, so I don't know if it's specified whether PSA is rising on ADT and Daro, but that would be of some concern. But he certainly withstood the test of time, right? This is a long interval from his original diagnosis. So despite high-risk disease, this is a patient who I think should be considered for salvage local treatment. This is the type of patient we'd see in our multidisciplinary clinic, see a surgeon for consideration of salvage prostatectomy, and radiation oncologist for the options there, either brachytherapy or additional external beam radiation therapy.
Yeah. All right. Dr. Hussain, thoughts?
Yeah, so I think we see quite a bit of these cases. I think that personally, when you see a patient like this, and if in fact the only thing that's positivity is in the prostate, I generally will loop in our urologist to actually confirm there's disease in the prostate or not. So that would be the critical part, and invariably they will do a biopsy. If there is, depending on the circumstances, certainly cryo would be there. I seriously doubt that any kind of brachytherapy is going to be done. And again, I'm not a radiation oncologist, but from my experience, I don't think that is done. The other thing, I think, with the era of more sensitive imaging, certainly a PSMA PET would be a good idea to see if there's any other sites of disease. One of the issues, I think, the PSA doubling time is also critical. And what we know is that the risk of developing METs is a function of very rapid doubling time. I happen to think that if you cannot have a definitive treatment for this patient, I generally counsel my patients unless they have a very rapid doubling time. If that's not the case, I usually continue monitoring and do not do treatment. Just because there is no real data that says doing anything is going to make this person live longer or live better unless there is local risk of disease progression, which is why I think a biopsy would be a good idea.
Yeah, fair. Dr. Fizazi, what about in France?
In patients with obviously non-metastatic disease, but castration sensitive, with local relapses, we try, I think, to be cautious with decision about second local treatments because there is clear evidence that this can be toxic. So it has to be really a balanced decision, and you need really to inform your patients. In patients with prior irradiation, we've been using brachytherapy in last years with some successes and actually, I think, quite mild toxicity. But again, we need more data, and this needs to be formally analyzed. We rarely operate on these men. There are exceptions, but that's rare. And also, cryo has been an option. Now, if the patient is castration resistant, we need to be even more cautious, I believe. Data from PSMA PET indicate that approximately 20%, 10 to 20% of these men seem to have purely local relapses. But I think the jury is out as to whether a second or even a third local treatment can still salvage these men. So we really need data ideally in a context of a trial.
Fair. All right, and I think we need to move on to our second video here.
The next case is from Dr. Nataliya Mar, a 68-year-old man who has status post-radical prostatectomy for a 4+3=7 prostatic adenocarcinoma, now with persistent PSA elevations.
I made the doubling time to be fairly slow. It's over 6 months. So the question is, what would you do here? Salvage radiation is pretty much the only option that can still offer a cure in this setting, potentially. ADT would not be a curative option here. This guy was offered both and he declined. He developed oligometastatic disease. He only had 2 pulmonary nodules. So the question is, how do we treat this? And there is some data, small data. This is not standard of care, that SABR, which is a form of targeted radiation to the metastasis, delays initiation of androgen deprivation therapy. So that's another point here.
So the question to be addressed in this case is not only the approach to M0 disease in a patient whose status post-radical prostatectomy, but also the approach to oligometastatic disease.
So Dr. Antonarakis, do you want to start us off?
You know, I wish the patient had considered salvage radiotherapy-based procedures because that is the second chance for a cure, but many people have reason not to do that. And of course, we must always offer that. We shouldn't just ever say, we'll start you on some intermittent ADT unless we've told them that salvage radiation plus or minus ADT is potentially curative. And then the patient unfortunately developed M0 disease with pulmonary-only mets. And, you know, the level 1 evidence would, in that scenario, teach us not to use intermittent over continuous. But, you know, there's recent literature about these pulmonary-only metastases that they're very exquisitely hormone sensitive. And in my practice, I would typically not do a stereotactic radiation-based approach to the pulmonary mets. I think that would be different if they were 2 bone mets. But for pulmonary disease, I would typically treat this person with enhanced endocrine therapy, and very likely the pulmonary mets and the other systemic disease would disappear.
Yeah. So in enhanced systemic therapy now, what is your treatment goal? Is he going on continuous therapy?
I think I would tell him that if his goal was to live as long as possible, so if lifespan was his goal, he does have, you know, technically visceral disease, so that this would be, at a minimum, ADT plus a novel androgen receptor targeted therapy. I would not be in a rush to give this gentleman chemotherapy, although that wouldn't be incorrect. In other words, triplet. I wouldn't do it for this one, and it would be continuous and lifelong.
Dr. Smith?
Yeah, so I agree with Emmanuel that these patients with pulmonary-only metastases have a good prognosis, and I have a clinic full of patients who are like, you know, outstanding responders, unusually durable responses. And some of those I have treated with intermittent ADT for that reason, and often they'll have very long disease-free intervals. I think one point to make here, in this case, we're missing some details like how long between primary treatment and development metastases. The other point is how sure are we that this is prostate cancer? I'm going to assume that that's been documented by a biopsy or otherwise, but in my career, I've certainly diagnosed a lot of primary lung cancers or other bad problems in restaging patients for prostate cancer.
Yeah, I think it's a key point. I think probably all of us would want to biopsy the lesion, right? You just can't be quite sure that this is going to be prostate cancer.
Yeah.
Can you speak to, because we've touched on it a little bit, of course, lung metastases are visceral, certainly, right? But there's visceral and then there's visceral. Lung is not the same as liver, right, in terms of metastases. So what are you telling the patient about expectations from having lung-only metastases? Liver only, I think it's a different conversation.
Yeah, so I'll take that. Yeah, so I tell patients, you know, they have metastatic disease. It's a chronic problem. The history with lung-only metastasis is favorable, and they have actually a very good prognosis. They're expected to live for, you know, 5 to 10 plus years.
Yeah.
Actually, sometimes I'm telling these patients that it's a good news that they have pulmonary metastasis and not anything else, to be honest, because purely lung metastases behave quite nicely, and they are very hormonal sensitive, as Emmanuel alluded to. So you know, in this context, it's a kind of good news for the patient, not having bone, not having liver metastasis.
So what regimen? PIS-1?
No, not necessarily. I mean, this is a relapse first, and PIS-1 was really for de novo patients. This is one reason. Second, it's pulmonary metastasis only. And I'm not sure we have sufficient data supporting the use of a triplet treatment for these men. And given, again, the expectancy for good outcome with a doublet hormonal therapy, I think this would be very reasonable in this case.
Yeah, fair enough. Dr. Hussain, last comment, 30 seconds.
Nothing other than I generally do biopsy those patients, especially if there's a solitary lesion, because I've had numerous cases of different cancer that was found. I do think there is a difference between having one lesion versus multiple lesions in terms of how much you're going to approach it with regard to triplet therapy versus doublet therapy. So all of these things there. And I do think there's an advantage because it sounds like this patient relapsed quite fast. I would definitely, the biopsy will give you even more advantage in terms of getting tissues for genomics in preparation for potential downstream treatment that might be necessary.
Yeah, there, absolutely. All right, so now we're going to move on to one of the slide deck presentations. And I'm going to speak to you about management approaches for patients with non-metastatic prostate cancer. So here's the outline. We're going to go through 6 studies in 8 minutes. So we're going to fly through this data fairly quickly. Hero, Stampede, Presto, Prosper, Spartan, Aramis. The last 3, of course, we arrange in that order simply because it spells out PSA. All right. So the phase 3 Hero study, I think people are familiar with this. It was the study that brought us relugolix, and it looked at patients with advanced prostate cancer of various categories, right? This could have included biochemical recurrence, newly diagnosed hormone-sensitive, advanced localized disease. And patients were randomized then to receive either leuprolide acetate, given in the traditional manner, versus relugolix, which of course is an oral LHRH antagonist. The primary endpoint was sustained castration at 48 weeks. And I think it's often forgotten that that's actually the primary endpoint because it's not necessarily what we've given the most attention to. So the endpoints are demonstrated here. Again, the primary endpoint, sustained castration at 48 weeks, but the secondary endpoints of sustained castration and recovery of testosterone at various time points. When we're looking at the baseline characteristics, the one thing we really need to focus on here is the cardiovascular risk factors because this becomes such an important part of the narrative of this study. And over 90% of patients were identified as having cardiovascular risk factors at baseline, which of course is not too surprising given the elderly male population, right, that's afflicted with prostate cancer. In the primary endpoint, this was a positive study. Relugolix certainly leads to a higher sustained castration rate at 48 weeks than leuprolide. A meaningful difference, at least statistically defined. But of course, the bigger story around relugolix was this slide, looking at the adverse events and looking at major adverse cardiovascular events. There was a significant difference seen, or a meaningful difference. I won't say significant, right, in terms of statistical significance, but a meaningful difference seen between the relugolix patients and the leuprolide patients with a higher rate of major cardiovascular events in the leuprolide-treated patients. And this became, I think, the major selling point, perhaps, for relugolix. Moving on to the Presto study. Presto was patients with high-risk biochemically relapsed prostate cancer, the patients we saw in one of the case presentations here. And it was testing combination therapy, that is LHRH therapy alone versus with the addition of apalutamide or the addition of apalutamide and abiraterone acetate, where each of the experimental arms were compared only back to the monotherapy arm, not to each other. The primary endpoint was PSA progression-free survival. We see the primary results here. Again, each arm, experimental arm, was compared back to the control of monotherapy. And in both cases, there was improvement in PSA progression-free survival, strongly positive results, although very similar results. In an analysis looking at the PSA doubling time, whether it was less than 3 months or 3 to 9 months, the benefit carried through. The doubling time really wasn't predictive or significant as a factor for the magnitude of benefit with the experimental arms. So all positive, regardless of the doubling time. And then in the time to testosterone recovery, again, very much the same, not a significant difference in testosterone recovery. All right, so now looking at the Stampede study. This was looking at abiraterone and prednisolone with or without enza in men with high-risk non-metastatic prostate cancer. The slightly complicated trial design in that this was actually a meta-analysis that was reported of two different studies, one looking at abiraterone acetate and the other looking at abiraterone with enzalutamide. In both cases, the control arm was LHRH monotherapy compared to LHRH plus either abiraterone or abi plus enzalutamide. Slight differences in the entry criteria and the definitions of high risk for the studies. Metastasis-free survival was strongly in favor of combination therapy with abiraterone and leuprolide in this population, abiraterone added to standard of care. And importantly, this carried over to overall survival. So again, you see a very strong hazard ratio favoring combination therapy in this population and really practice-changing results then for radiation in most of these patients, in addition to ADT and abiraterone. This was given for 2 years. All right, and then the last 3 studies we'll look at in the last 2.5 minutes here. Long-term use of apalutamide, enzalutamide, and darolutamide for patients with non-metastatic castration-resistant prostate cancer. So the Prosper, Spartan, and Aramis studies all had very similar trial designs and all were powered to look at the then novel endpoint of metastasis-free survival. In Prosper, patients were enrolled based upon biochemical occurrence with a very standard definition and randomized to either ADT or ADT with enzalutamide, again with the metastasis-free survival endpoint. In Spartan, again, same essential trial design. There are, if you look closely, slight differences in the eligibility based upon pelvic lymph nodes and limits on lymph node size, but nevertheless largely similar. And in Aramis, again, very similar. In all 3 studies, importantly, emphasize the importance of PSA doubling time must have been 10 months or faster to enroll and study. So, you'll hear us talk about PSA doubling time in these settings and how important that is to select patients who are eligible to move on to therapy with one of these oral agents. I think the comment was made in one of the cases that a doubling time of 6 months was considered slow. Actually, I think 6 months is what we consider fast and eligible for escalation of care because of the correlation between doubling time and the time to expected metastatic disease. As we see that scale of doubling time, it's somewhere around 8 to 10 months where we see this inflection point where the risk starts to go up. So 10 months is used as the cutoff then for these 3 studies. Putting all 3 studies side by side, the endpoints again are very similar, primary endpoints all the same, some slight differences in the secondary and exploratory endpoints. But here again, what we see in these studies is very similar results. I would say that there is, in my opinion, and you see if the panel disagrees, but no significant difference between the 3 options in terms of the primary endpoint. They're all strongly positive, very similar hazard ratios, very similar long-term results. All 3 drugs then approved in this setting for non-metastatic CRPC. All right, so now that's the end of my module. We're going to move on to the next where we have more cases, more videos.
The next case is presented by Dr. Georges Azzi, a 70-year-old man who presented with metastatic disease.
We did a PSMA scan and that was read as a super scan. Almost every bone in his body was involved. Given this kind of high tumor burden, I decided to go with the chemo ADT darolutamide combination for him, and it seems to be doing pretty well. He had pretty significant bone marrow involvement when we started chemo. His hemoglobin, when he presented, was about 5, and he was requiring constant transfusions. And now, after responding to the treatment, he actually a hemoglobin of 10 and keeping it up without any transfusions. The question that arises is in second line, when this patient progresses, would they now go immediately to lutetium PSMA because the patient has received ADT and a novel agent and chemotherapy?
Before a discussion of this case, let's hear one more from Dr. Swati Vishwanathan, another patient presenting with metastatic disease, but this case is complicated by the patient's age.
He's a 96. He's probably my oldest patient, and he presented with de novo metastatic prostate cancer. I would be very hesitant to do chemotherapy in him. So is it reasonable to do darolutamide alone in him? It seems to be the most well-tolerated drug. The next question I have is, in what clinical scenarios are they preferring to use Degarelix over Lupron?
Any question about Relugolix?
I have not seen it being very widely used, at least around me. I was thinking I would use it probably in patients who have significant cardiac issues, and I have concerns about sometimes compliance with pills.
So in summary, 2 patients treated with hormone-sensitive metastatic disease, raising the common question about the role of triplet approaches like the Arisens regimen, although one wonders where the phase 3 evidence is of benefit of adding chemotherapy to ADT and secondary novel endocrine therapy. A related question is optimal second-line treatment of patients receiving an Arisens-like triplet, and, for example, the role of lutetium in these patients. Another question is the optimal approach to hormone-sensitive metastatic disease in the very elderly, and in what situations, if any, are faculty using GnRH antagonists, and how they take into account adherence issues with an oral agent, for example, Relugolix.
So, Dr. Antonarakis, why don't we start with you? The first case, right? We had a man, the heavy disease burden, heavy marrow involvement, went through triplet therapy, and the question comes up: what on progression? Is he eligible for lutetium? Where would you go with this patient? What's your approach to managing this patient?
You know, before we get to that, one thing that caught my attention was, the myeloproteic anemia at diagnosis. That's a very poor prognostic sign. Whenever I've seen that, when people present with hemoglobin of 5, I mean, that is pretty scary, and I'm glad he's doing well for now. He most likely, despite the triplet, will develop CRPC within 18 months or less, probably 12 months or less. I hope I'm wrong. And, he would have 2 or 3 options. Of course, one would be cabazitaxel. Second would be lutetium PSMA 617, which he would be eligible for because he's received both a novel AR-targeted therapy and a taxane. Of course, we shouldn't forget about radium-223 if he had bone-predominant and symptomatic disease. But I would start with a PSMA PET scan upon PSA progression. And that could help us because if this is a more dedifferentiated version with lower or absent PSMA, that will take lutetium off the table and might prioritize radium or maybe a second chemotherapy like cabazitaxel.
Now, as a practical question, when is that patient getting germline and somatic testing?
First visit.
First visit.
Right away.
Right. Absolutely.
Yes. Agree.
100% agreement on this panel, correct?
Yes.
Yeah. So, obviously
If I may
that might...
just make a comment,
Yes.
one thing just for the attendees here, is one of the things is if he doesn't have soft tissue disease to biopsy, assuming he got biopsied, just be mindful of the fact that when it comes to bone biopsies, you need to talk to the interventional radiology and the pathology group, where you ask that you need cores, multiple cores, and no acid decalcification. Because the minute they do that per regular sectioning and staining, the tissue is destroyed, you cannot do any NGS on it.
And then the practical question that sometimes comes up of, what about cell-free DNA testing? Is that a problem? Can we be confident in it? What do you tell the community physicians when we get that question? Do you feel comfortable with it?
I do.
Yeah.
Yeah, and patient, particularly the first patient, it'll be
That
valuable.
disease burden, there's plenty of cell-free DNA, right?
Absolutely, yeah.
Except negative cell-free DNA does not mean there is no tissue issue. So you can do that, but then the tissue to me is the ultimate source. If you find
Absolutely.
the testing negative, definitely jump on it.
And on top of that, don't forget that the prostate cores can be used also for
Correct.
analysis.
Correct.
Especially in this situation, you will have probably a very recent biopsy. For example, for BRCA assessment, BRCA alterations are quite an early event, so you will not miss much looking at the prostate cancer biopsy, prostate biopsies, as opposed to bone biopsies or other metastatic sites. So I think this is quite, easy doing. And
Yeah, absolutely. What about, Dr. Fizazi, the question then about the very elderly patient, 96-year-old? How would you approach that?
I think that's the main challenge we will face in the coming years. We see more and more of very elderly patients, and sometimes with very aggressive cancers. Because, sometimes you might say, well, it's localized prostate cancer, it was detected by chance, blah, blah, blah. You don't treat, fine. But sometimes it's really bad cancer, so you have to try doing something. So obviously we don't have evidence for these men. I have to say that more and more in the ongoing trials, I see a trend for accruing more patients in the elderly, which is good. For example, the three mCRPC trials you just mentioned, the median age was 74, if I'm not wrong, so reflecting pretty much the reality. But for frail patients, we are really missing something. We are currently conducting in Europe randomized trials for these men who are vulnerable based on very advanced age or severe comorbidities, where we are randomizing ADT alone versus ADT plus darolutamide, because we don't really know whether we can safely use treatment intensification in these men.
Yeah. Dr. Smith, what about that question about darolutamide as first-line therapy for the 96-year-old?
Well, I wouldn't be in a rush to add a second drug. I'd want to see that this 96-year-old tolerated androgen deprivation therapy. If there were concerns about adherence, I would have no problem using degarelix. It's probably a class effect of improved cardiovascular safety, such as it is. And I would consider intensification with an AR pathway inhibitor. My first choice would be darolutamide based on its safety profile, if you could get it for the patient.
What would you quote this gentleman about the just progression-free survival from ADT alone or LHRH therapy alone in the first line?
Well, without knowing, well, except the de novo, I guess,
he's 96,
high burden
de novo.
disease. Yeah. So from Stampede, it's pretty poor, like progression within 18 months, 14 months, something like that.
In a man
but that might be a long time in a 96-year-old man.
median overall survival of 24 months, right? From all other causes.
A little longer than that, but yeah.
Fair enough. We have another case presentation to get on to.
The next case is presented by Dr. Eric Lee.
70-year-old man admitted to the hospital with back pain, found to have metastatic prostate cancer, lots of bone bents. Initial PSA was 180,000. While hospitalized, he developed AFib with RVR. He was started on amiodarone and apixaban. In the outpatient setting, I opted for the Arisens regimen. In this case, I chose relugolix instead of leuprolide because of the cardiovascular risk. And I was very fortunate that I was able to get that pushed through insurance. And he's having an excellent response. He's been on therapy for a few months now. His pain is completely controlled. So my questions are, what are the investigators' experience regarding the CNS toxicity of darolutamide? And how does it compare to, for example, dose reducing, for example, enzalutamide? Another question is, darolutamide is only approved, I believe, to be used upfront in like this Arisens regimen, where you combine it with chemotherapy. But do the investigators have any preference among the oral anti-androgens in regards to side effect profile, fatigue, weakness, risk of falls?
180,000 PSA, that's got to be one of the higher ones you've seen. I assume he never had a prior PSA?
No, there's a gentleman who never went to see the doctor.
In summary, the issues here are the relative tolerability issues of the available anti-androgens and whether darolutamide can and should be given without chemotherapy in hormone-sensitive metastatic disease.
Dr. Hussain, you want to take that?
Yeah, I think it can. I don't think it's an issue. We live in the United States, so insurance coverage is the biggest barrier. when it comes to these issues. And so certainly if there was any concern about, health medical issues where you feel this patient is better off, like if there's risk of falls, if there are seizure issues, things of that sort, certainly abiraterone and prednisone, if there's no contraindication, that's one option. The other option would be trying for darolutamide. You can always work with your pharmacist because they can really help with trying to get the prescription moving forward, and sometimes peer-to-peer and stuff like that might help in terms of getting the approval moving forward.
This came up in the last case as well. We didn't quite talk about it, but where do you think about using LHRH agonists versus antagonists?
My approach, particularly patients with highly symptomatic de novo metastatic disease, is to use an antagonist. We typically use degarelix, and then once the patient's beyond the risk for flare, switch to a more convenient GnRH agonist.
Yeah. So really convenience drives the decision making.
Yeah. So it's
initially quick response
for the switch, but
for
yes,
the, switch.
the reason to start with the antagonist is the rapidity of action, and I can start treatment the day I see the patient. And while relugolix does have a rapid onset of action, it requires a prescription and insurance pre-authorization. So there's no way I can give it as fast as I can give degarelix.
Dr. Fizazi?
Yeah, just commenting on this gentleman with cardiovascular comorbidities, I think we should really learn better to work together with cardiologists. And the beauty here is that you do have some time to do so. You can start your ADT with an antagonist, for example, refer your patient to the cardiologist with at least, I think, 2 discussions. Number one, he has an atrial fibrillation. Is there a possibility to reduce that safely? And I think you'll feel much more comfortable if indeed he has a normal cardiac rate. Number two, if not, which cardio drug will be ideal to combine with other cancer drugs? Darolutamide is quite easy to combine. AbbVie also pretty much. Enza is not that easy to combine. And actually you will not see extra toxicities from the other drugs. It's the opposite. They will not necessarily work. And if it's a cardiac drug, this is really an issue. Because of the enzalutamide interaction. So those are really the discussion we should have, and I tend to tell my patients, tell me who your cardiologist is, give me his address, I'm going to call him or I'm going to write him, and then we will have a direct interaction. And I think this is getting more and more important.
Absolutely. All right, I think we move on to our next talk here.
So thank you very much for the opportunity. My talk will be focusing on the optimizing the care of patients with metastatic hormone-sensitive prostate cancer. So I wanted to just begin with a brief history. Ever since the original observations by Dr. Huggins with regard to the fact that prostate cancer is androgen-dependent, driven and dependent disease, the fundamental backbone of therapy since the 1940s till now has been really suppression of testosterone, either with an orchiectomy historically or subsequently with the different medical treatments that have been developed. Now, the reality of it is this, is 9 out of 10 men will in fact respond to androgen deprivation, irrespective of what you're going to be doing in terms of gonadal suppression or orchiectomy. The vast majority will end up progressing, and this has led to different strategies over the past 7 decades, literally, in terms of the different treatment strategies. And so I'm not going to go through all of them, but I just want to highlight 2 things. One of them is the concept of therapy intensification is not a novel concept. This has been done in the past with the different times of, different decades with different agents, either chemotherapeutics, AR inhibitors, other factors there. In reality, I would say during my training and early career, probably the biggest signal was actually the concept of combined androgen deprivation by essentially suppression of testosterone production and AR signaling inhibitor. The first one was flutamide, then we got bicalutamide, and we moved on. Now, in reality, all of these combo treatment had a signal, it's just that the magnitude of the benefit was not big when it comes to overall survival. And there were like literally for a decade or more debates as to the value of these agents. Of course, other concepts were discussed earlier today, and then the issue of intermittent versus continuous therapy, androgen deprivation plus bone-targeted therapy, and other, and Dr. Smith is here. He's, I think, led one of the cooperative group trials. Now, since 2015 onwards, the concept of therapy intensification got rejuvenated with really much better return on investment, so to speak, in a medical sense, with the newer agents that we have. So this is just a summary of all the trials that were done looking at combined androgen deprivation, starting with the first trial, which was a SWOG trial led by David Crawford at the time, and to demonstrate that there was an advantage, but the advantage was not huge, and that really did not change the practice as much. Moving forward, as therapy improved in the concept of in the setting of patients with metastatic castration-resistant disease. And what I have labeled in turquoise blue are the different agents that have been approved by the FDA, starting actually with docetaxel and then other AR inhibitors and other agents. Several of these agents got moved into the hormone-sensitive space. And so we've seen a much bigger signal with regard to benefit, starting with CHARTED, which basically randomized patients to androgen deprivation with or without docetaxel, STAMPEDE with abiraterone, LATITUDE with abiraterone, TITAN with apalutamide, ENZAlutamide with enzalutamide, and there are other trials that were done also, the JUTAC and other trials that were done also in this space. And more recently, we are entering the era of triplet therapy. So one of the critical prognostic factors in prostate cancer is the recognition that the disease volume and the disease extent and location has an impact on outcomes with regard to having bad prognosis. The early observation was made in the original trial, and the SWOG definition was basically a high-risk or low-risk disease, extensive or not extensive disease. And then that was confirmed similarly in the intermittent trial. And as we moved forward with Dr. Sweeney designing the CHARTED trial, the definition was modified with regard to the risk of disease, adapting both the SWOG definition with the MD Anderson definition. And this has sort of led to the design of the CHARTED trial, which was the first trial to demonstrate actually an overall survival advantage with the addition of chemotherapy to androgen deprivation with the use of docetaxel. And essentially, the high volume disease is required either visceral disease or 4 or more bony lesions with at least 1 beyond the axial skeleton. And anybody else would have been low volume. And as you see here with the CHARTED trial, the benefit was predominantly in the high volume patients. The low volume patients did not seem to benefit much from the addition of docetaxel. The LATITUDE trial is here, and this was was actually the first trial that evaluated the combination with abiraterone in newly diagnosed metastatic patients. And again, this trial, the first report by Dr. Fizazi, actually now 6 years ago, demonstrated a benefit, but a very short follow-up. And then subsequent data, again, confirmed the advantage with regard to the overall survival. And then the enzalutamide was evaluated in 2 trials, the ENZAMET and the ARCHES, and both of them actually demonstrated, again, an overall survival advantage. So far we're talking doublet treatment. And apalutamide is the other agent that was reported first by Dr. Kim Chi 4 years ago, and then a follow-up again demonstrating, again, the confirmation of the advantage with regard to overall survival. Now we've entered the era of triplet therapy, and this is really a basic principle in oncology. The trial, the PEACE-1 trial, again, Dr. Fizazi is here, so he can answer the questions better than I can do. But basically, this evaluated the combination of androgen deprivation with abiraterone prednisone in de novo metastatic hormone-sensitive prostate cancer, and some of these patients actually had docetaxel also. And what you see at the bottom I can't point to it, but at the bottom there, that there is an advantage, but the advantage appears to be mostly in the patients who have high volume disease. Although I should point out, and I would love for Dr. Fizazi's comment, is whether the observation in the low volume patients was actually premature, that more survival follow-up is needed. And then finally, the second triplet, which was the trial led by Dr. Smith, the Arisons, where triplet therapy was basically done with darolutamide versus androgen deprivation, docetaxel, and placebo. And the first report was last year, demonstrating an overall survival advantage and other secondary endpoints advantages, including castration, delay in progression to castration-resistant disease, time to pain progression, and so on. And today we reported the results by subgroup analysis based on the volume of disease. And what's interesting, again, high volume patients clearly benefited. Low volume patients' hazard ratio basically is favorable, although I do think that we need more follow-up to see the trends in there. Just because I think it's not long enough. And of note, actually, both in the high volume patients, the triplet arm has not, the median has not been reached, and the low volume patients in neither treatment arms, the median of survival has been reached. And this is by the risk groups based on the definitions of the other trial, and what you'll see here, there was really favorable trends with hazard ratios in both low risk and high risk groups of patients. So with that, the question comes up, what is the optimal therapy and how best to choose? So I would say that in the doublets, in the context of androgen deprivation plus docetaxel or AR inhibitors, clearly these are superior to androgen deprivation alone. Based on charted, I would say the benefit is of docetaxel is in the high volume patients. When it comes to triplet, clearly with the PEACE-1 data, the triplet with ADT, doci, and abiraterone improved overall survival primarily in the high volume patients. However, again, I would love to hear from Dr. Fizazi regarding the follow-up on the low volume patients. Arisons, the benefit appeared to be across the spectrum, basically, in this regard. I do think that the question today, in my mind, is in the era of more potent AR inhibitors, is chemotherapy needed? And is it even needed in not just in the low volume patients, but definitely is it really needed in the high volume patients? And I think that's the kind of question that would need to be addressed in really prospective randomized trials. So with that, I want to end with a couple of points. One of them is this, is the implications of what we're doing right now in the hormone-sensitive space as patients then move into castration-resistant disease. And I labeled, I have it colored in turquoise blue. All of the turquoise blue agents, we've moved them already into the hormone-sensitive space. So if a patient progresses, what do we think the response is likely to be to these other agents, which were actually developed in an era where we didn't have all of these things? And I think these are the kind of questions that we need to address. So in conclusion, doublets and triplet therapy improve overall survival in metastatic hormone-sensitive disease. The emerging data indicate an advantage to adding AR inhibitors to androgen deprivation and docetaxel, but the benefit is not entirely consistent across all disease extent or type of AR pathway inhibitors. I would say, again, in the era of potent AR inhibitors, trials are needed to evaluate the need for docetaxel in combination with androgen deprivation and AR inhibitors. I do think there are several opportunities to consider to try to do better for our patients. Better imaging with the PSMA PET and other imaging provides a window of opportunity, because then the hope is that you're going to get less bulky disease where the potential impact of treatment is better. And then, of course, the role of targeted therapy in molecularly pre-selected patients. And the other question, which we discussed today also, is what about therapy de-intensification in long-term responders? If yes, when and who? And that's it.
Excellent. All right, we'll go into our video. Thank you, Dr. Hussain. Here we go.
The next case is presented by Dr. Amber Xu.
This is a gentleman, 63, presented with de novo metastatic prostate cancer with lymph node and diffuse bone mets. The patient favored the non-chemo option to begin with. He had an initial response only for about half a year. And then his tumor markers start to rise, his scan showing progressive bone mets. I checked next-gen sequence and discovered this androgen receptor T878A alteration that was new when he progressed on abiraterone. So at the time, I thought maybe, this is a mutation leading to resistance. So we started him on chemotherapy with docetaxel. He had a short response. However, about a year later, the disease again progressed, mainly in the bones. We tried another line of chemotherapy with cabazitaxel, did not work. My question to the expert, number one, is how do they sequence and how do they incorporate the leucine? My other question is, what exactly is the significance of this AR mutation?
In addition to seeking more information on the use of triplet therapy, the main question here is the significance of the androgen receptor T878A alteration.
All right, Dr. Antonarakis, you want to take first shot?
Well, there's many ways that the AR can remain operant in CRPC. We have amplifications of the gene, we have splicing variants, or we can have mutations in the so-called ligand binding domain. In other words, the area of the protein where the ligand, which is testosterone, binds. And some of these mutations, they're called promiscuous. Just leave it at that. And what that means is that other sex steroids or other adrenal steroids other than testosterone can bind and stimulate. So this one is a progesterone activated mutation. So progesterone can basically become like testosterone and stimulate that receptor. That is kind of, at this point in time, more of a theoretical consideration. It wouldn't change my management of this patient unless I had access to a drug that Karim is working on that ablates the adrenal gland and abolishes all the steroids.
Should I comment on that?
Follow?
Sure. Yeah, I think that's perhaps a new field that's recently been opened. We know that mutations occurs. They do occur under pressure, under therapeutic pressure. We don't see them up front. They appear more and more under abiraterone or enzalutamide pressure or similar drugs. And until recently, we didn't really know what to do with them. We hypothesized that indeed blocking the making of non-androgen hormones, such as progesterone in this situation with the 878 mutation, which is one of the most frequent, or also corticosteroids, which can stimulate another quite frequent mutation, the 702, can actually be active. And to do that, we've been using a drug, ODM-208, which block a key enzyme in the making of all steroid hormones. So it's just the first enzyme downstream the cholesterol. It's called CYP11. And actually, it seems to be working quite nicely in these men. The response rate in patients who have exhausted basically everything, abiraterone, enzalutamide, taxane, basically everything, the response rate is over 50% and actually more in the 60% range, with some very durable responses. We had some patients responding for years on this agent. So I think this is very promising, and I'm saying that because we had a phase 1 trial, but we also had a confirmatory cohort of men with mutations, and actually we could really reproduce what we found in the phase 1. So hopefully we'll have a phase 3 starting soon.
Beautiful. We will look forward to those results. All right, we're going to move on to the next video.
Dr. Priya Rudolph is treating a 78-year-old man with metastatic disease and 2 common complications of taxane therapy.
He's had excellent response to docetaxel. Unfortunately, I had to hold treatment due to significant bilateral pleural effusions, which are non-metastatic. It is a drug side effect, despite pre-medication with dexamethasone. It got to the point where I subsequently switched him to cabazitaxel, and again, he had very good response to cabazitaxel. However, he was admitted with hematuria. So unfortunately, two good chemotherapies that have side effects which are not limiting, but certainly give pause as far as whether or not we want to continue on with these treatments. He would be a good candidate for treatment with lutetium. The bigger question, exactly at what point do we start treatment with lutetium? Since he has bone-only metastases, he would also be a candidate for radium. And I wondered if we should maybe start with radium and then save lutetium for later when he has possible lymph node or visceral metastases, or how investigators toggle between the two treatments if they do.
In addition to seeking input on the pleural effusions and hematuria related to taxane therapy, an important question for the faculty here is the sequence of using lutetium and radium in patients with metastatic PSMA avid bone-only disease.
Dr. Smith, you want to kick us off?
Yeah, so if I can, I'll take the second question.
Okay.
Yeah. So I don't think we know. We don't have comparative data. I say personally, I'm more compelled by the PSMA lutetium data and would prefer to start with that, even in a patient with bone-only metastases.
Yeah. Anybody disagree with that, Dr. Fizazi?
No. I would do probably the same. But at least we can say that there are quite reassuring data suggesting that you can use, at least in some patients, radium followed by lutetium PSMA. So if your patient already has received it, lutetium PSMA remains a reasonable option. I may take the first one. I don't know if it's crazy, but I saw that sometimes this is quite exceptional. It's really unlikely because he has a taxane-sensitive disease, but he cannot really receive the two taxanes for toxicity reasons. In similar cases, I've been proposing paclitaxel simply, and we don't have phase 3, unfortunately, but there were phase 2 data with paclitaxel 20 years ago. It actually worked in terms of response rates. So, and in similar situations, I've been using it, and it also worked. So I think this is reasonable, but I'd be curious to see what others do.
I mean, I think the issue of hematuria needs to be evaluated. I don't think you have to assume that this is a side effect of the drug. And honestly, for decades, we've never seen it. And hematuria can happen. People can have stones. They could have, bladder cancer, or at least, non-muscle invasive or something like that. So I would not switch treatment without a full evaluation.
But
if in fact you have no explanation or no other source, then I would favor lutetium.
Absolutely understandable, right? I mean, we don't want to abandon a limited number of drugs too quickly if we don't have to.
Yeah.
Emmanuel, radium-223, I mean, you've brought it up. Would you slide it in first, or do you jump into lutetium?
Well, you have to have symptomatic disease. That's part of the FDA label. So no symptoms, it's hard to get radium reimbursed, although if you put 1 out of 10 bone pain, that's enough. So just don't put a 0 out of 10 pain score. And then the other issue is, we're learning a lot about the radiographic features that predict PSMA lutetium 617 response. So we've heard about the SUV mean. Now, many nuclear medicine physicians are not reporting that, and at our center we started to ask for it, so now that's part of their routine report. If the SUV mean is above 10, the chance of benefit from lutetium PSMA 617 is high. And we all see patients that have 100 bone metastases and they have SUVs of 5, 6, 7. Yeah. That's not someone that I would be terribly excited about lutetium PSMA as the next step. Where I might reach for radium first in that context.
Fair enough. All right, I think we'll move on to our next talk then. All right, Dr. Smith.
So I've been assigned an eclectic group of studies to cover, so I'll do my very best. And we're really talking about newly diagnosed mCRPC, or so-called what we call first-line mCRPC. But in the very thoughtful comments we heard from Dr. Hussain, it's the intensification of systemic treatment in mHSPC that really has these downstream effects on how we manage subsequent mCRPC. And current NCCN guidelines reflect that. This is this 2x2 grid. organized according to prior treatment with docetaxel and or an AR pathway inhibitor. So really the big driver behind therapeutic selection is going to be what treatment the patient has previously received. Adding to this complexity is a number of approved therapies and the requirement for either molecular or image-based screening for some of those newer treatments. So based on the results of the IMPACT study long ago, Sipuleucel-T was approved for mCRPC in 2010. At that time, the only life-prolonging therapy in mCRPC was docetaxel, and that has led many to question whether Sipuleucel-T still has a role in a contemporary treatment landscape that includes, for example, potent AR pathway inhibitors. To address that question, Raina McKay and colleagues conducted a retrospective cohort analysis using a Medicare research data set. That study included 6,000 patients with mCRPC who received treatment with Sipuleucel-T or an androgen receptor pathway inhibitor. And they observed that Sipuleucel-T was associated with improved overall survival compared to an androgen receptor pathway alone. This is, of course, hypothesis-generating data. This was not a randomized controlled trial, so take that observation for what it is. The other couple of other interesting observations from this study were that treatment patterns were highly variable, and they observed about 140 different patterns of sequential treatment in mCRPC, kind of staggering. The other sort of disappointing finding was that many patients in this cohort had received only one line of therapy for mCRPC, and less than half had received more than 2 lines in an era where there were 7 approved therapies for mCRPC. So we have a lot of sort of educational need in terms of addressing unmet needs in mCRPC management. Based on a solid non-clinical rationale, a number of studies are looking at combining PARP inhibitors with AR pathway inhibitors, and Emmanuel is going to speak on this topic in some length, so I'll keep my comments brief here. But PROPEL is a randomized controlled trial of abiraterone acetate plus or minus olaparib. This is first-line mCRPC. Patients were randomized to abiraterone plus olaparib or abiraterone plus placebo with the primary endpoint of rPFS and a secondary endpoint of OS. This was an all-comers study. Patients did have testing to determine homologous recombination repair status, but they were enrolled regardless of that status. The study met its primary efficacy objective with improvement in an rPFS in favor of the combination arm. Shown here are the subgroup analysis that were published by Noel Clark and colleagues last year, showing that there was a significant improvement in rPSF in both the biomarker positive and biomarker negative cohorts, with a larger effect observed in the biomarker positive group, as you might expect. This was updated today at the meeting this morning with overall survival data, and that reported trends that were not significant with improvement in overall survival in both groups. So that might be a feisty area of discussion among the panel. Magnitude is another study that looked at combination therapy. It looked at abiraterone with or without niraparib. This had a very different study design, so patients were prospectively enrolled into 2 different cohorts, biomarker positive and biomarker negative, and those cohorts were analyzed separately. The biomarker negative cohort enrollment was discontinued early after an interim analysis met futility boundaries. The biomarker positive cohort was then enrolled to completion, and the analyses were conducted per study protocol. In the biomarker positive cohort, the primary study objective was met with a significant improvement in rPFS in favor of the combination, hazard ratio 0.73, with the greatest effect seen in patients with BRCA2 and BRCA1 mutations. TELEPRO-2 is a phase 3 study of enzalutamide with or without talazoparib, so a different ARPI partner. This too is first-line mCRPC. Patients are randomized to enzalutamide plus talazoparib or enzalutamide plus placebo, with the primary endpoint of radiographic progression-free survival. And many, if not all of you, saw the results of this presented today. It too met its primary study objective with significant improvements in our PFS. In subgroup analysis, there was a significant improvement in both biomarker positive and biomarker negative patients. The magnitude of the treatment effects observed were broadly comparable to the PROPEL study as much as we can compare between trials. There's also a strong rationale for use of CDK4/6 inhibitors in prostate cancer, as summarized here. There are a number of studies looking at CDK4/6 inhibitors as monotherapy, as well as combination therapy with androgen receptor pathway inhibitors. I'll just comment on two here. Cyclone 2 is a phase 2/3 randomized double-blind placebo-controlled trial looking at abiraterone with or without abemaciclib. It's really first-line mCRPC. Eligible subjects will be assigned to, have been assigned to abiraterone prednisone plus abemaciclib or abi-pred plus placebo, with the primary endpoint of radiographic progression-free survival, with key secondary endpoints including overall survival. This study is fully accrued and ongoing. Subsequent studies, Cyclone 3, same treatment arms, looking at high-risk metastatic hormone-sensitive prostate cancer. Again, same treatment group, 900 patients, with the primary endpoint of radiographic progression-free survival, and key secondary endpoints including time to castration-resistant prostate cancer and overall survival. So I'll just summarize by saying the management of metastatic castration-resistant prostate cancer is currently complex for a number of reasons, including important considerations of prior therapy, the introduction of a number of new therapies, requirements for molecular and image-based testing to select certain one of our newer therapies. This complexity will only increase with time as we anticipate new drug approvals and an emerging role of combination strategies. Thank you.
Excellent. All right. Thank you very much, Dr. Smith. We will get into a couple more videos here then.
Dr. Swati Vishwanathan is treating a 76-year-old man and wants to learn more about the clinical significance of a recent genomic finding.
Tumor NGS did show a pathogenic ATM mutation. So my question for this case would be, are they considering olaparib in non-BRCA1, BRCA2 HRD mutation or genetic alterations? Because I feel in that profound study, the majority of the benefit was for patients who had BRCA1 and 2 mutations, although they did include other genetic alterations. But what was their experience in response specifically in terms of ATM and other mutations like CHEK2? And I subject him to a PSMA PET scan, and he does have bony mets and also multiple areas of lymphadenopathy, specifically supraclavicular and periaortic lymphadenopathy. This patient did choose olaparib. He was on it for 7 months, tolerated it very well, except for some mild nausea.
Any questions you'd like to see the faculty discuss about the use of PARP inhibitors in general in prostate cancer?
If a patient now walks into the clinic with BRCA1/2 mutation, would they be using olaparib for all those patients? Would it be their first choice? That was something I would love to know.
So in summary, the issue for which more input is requested here relates to the significance of the ATM finding and also other non-BRCA HRD mutations of interest. Also, the role not only of PARP monotherapy, but combined treatment with a PARP inhibitor and, for example, abiraterone or other novel anti-androgens.
So Dr. Antonarakis, why don't you take the first question?
So a number of things to consider here. So the natural history of ATM-mutated disease versus BRCA2 disease is very different. The ATM patients tend to have a better natural history, are more hormone sensitive, and are more taxane sensitive. And the PARP inhibitors are not generally going to work as well in those patients. You might get some cytostatic effect where you have stable disease for a number of months, typically not objective responses or PSA responses. Olaparib as a monotherapy is approved for ATM mutations. It's one of the 14 genes on the panel. But that would not be my first, second, or third choice for this patient, although with BRCA2 it might. And then the last thing is there's this phenomenon of clonal hematopoiesis of indeterminate potential CHIP. And we now know that it probably doesn't have indeterminate potential. It has a lot of prognostic potential for cardiovascular diseases, inflammation. But if you are doing a liquid biopsy, a circulating tumor DNA test on these patients, the ATM gene is one of the most commonly affected genes in CHIP. So you could misascribe. In other words, you might think that the ATM is coming from the tumor if it's a blood-based ctDNA analysis, and it could be coming from the leukocyte, and those patients will not respond.
And we saw on the data from the Seattle group, right, approximately 50% of ATM aberrations in cell-free DNA in mCRPC patients is actually from CHIP. So it's not a small number, right? BRCA1/2 not associated with CHIP at all, but ATM is, so certainly something that needs to be evaluated if you're thinking about treating. Absolutely. Dr. Fizazi, how about this question of combination then with PARP inhibitors and second-generation hormonal therapies?
That's a tough one. So I would say that what we've learned from the 3 trials, I believe, the olaparib, niraparib, and now talazoparib. Number one is that for BRCA patients, using a PARP inhibitor is really a must, unless you're using a platinum. And probably we should use this agent as soon as possible when patients develop mCRPC. The next question being whether we should use them even earlier in mCSPC, and this is currently assessed in phase 3 trials. And to me, this is again the most important finding from these 3 trials. The magnitude of the benefit from PARP inhibitors in BRCA patients is just big. Now, for patients without BRCA alterations, what we've learned from TALAPRO-2, I guess, is that the PROPEL finding is not an artifact, it's a true finding, and this is really why we wanted to see this data as soon as possible. And having said that, we probably have to address 2 questions. One is a scientific one is a medical one. The scientific one is why patients without BRCA alteration seems to benefit from this combo of AR targeting and PARP. Is it because our test is not a good one and we're just missing BRCA alteration? It could well be, to be honest, especially deletions. Number 2, possibility, hypothesis, and this is mostly what people say. I'm not necessarily completely convinced. Targeting the AR together with a PARP inhibitor produce a BRCA-ness environment, and it works. Okay, maybe. Number 3, what we call PARP inhibitors has another property which we don't really know about. And this always happened in the history of medicine with many drugs. So whatever the reasons, we had to tease this out and find the true reason, because this can be potentially a new angle to better treat patients. Now, besides the science, I think we have a medical question now. And the medical question, at least to me, is whether this is good enough for my practice. We do see rPFS improvement in both PROPEL and in TALAPRO-2, approximately, say, 8 months, 9 months. But it's, at least now, pretty much alone. We don't see other benefits in terms of pain or time to pain deterioration, quality of life, overall survival, skeletal-related events. And at the end of the day, as a doctor, I want my patients to live longer or to live better or both, ideally. But here we only have an image that takes its time to switch from white to black, if you will. So I'm not completely convinced right now, medically speaking, and especially also because this comes together with significant toxicity. The incidence of anemia is quite important, And it's not just anemia, it means fatigue for the patients and the need for transfusion, probably somewhere around 40% transfusion rate. So I think we probably need more, at least I need more, to be convinced for my patients, not even speaking about the cost for the society or for the patients or for the insurance. But again, I'd be very happy to hear colleagues on that, because I think it's not an easy issue, to be honest.
Yeah. Dr. Hussain, do you want to comment?
Yes. So I think the issue is going to be regarding maybe first comment I should make about the BRCA genes versus non-BRCA. I would say from all the trials that we look at, just by sheer number, probably the biggest driver of the benefit in the patients who are being pre-selected is the BRCA, is specifically BRCA2. Even BRCA1 is not as good as BRCA2, just to highlight. One of the things we looked at when it comes to ATM and CDK12 and other factors was the fact that whether the timing of giving the PARP inhibitor in relationship to prior chemotherapy has an impact on response. And as it turns out, it looks, again, this is a post hoc data, which we presented and was included in publication. The answer is yes. And so surprisingly, for ATM patients, it seems after chemo is better. For BRCA, it's not really a huge difference. So there are some subtleties in there. I think decision about using the agents are going to be driven also by, do you have time to see if the patient's going to respond, or if the patient's having a lot of significant rapid progression symptoms and things like that, that would help you make decision. So the concept of combining basically a PARP inhibitor and AR inhibitor goes back to work that was done by Dr. Karen Knudsen and colleagues with regard to actually co-targeting the pathways to essentially create a synergistic sort of lethality, so to speak, in there. In reality, I've done trials with different PARP inhibitors and so on. The reality of it is two things. One of them is that not all PARP inhibitors are the same, and I think we've seen the data differences. Two, putting the two drugs together, probably the biggest return on investment is going to be in the patients who have the alterations as opposed to the intact patient population. Three, the issue of side effects are real, and I think we saw that in the Talapro trial and the other trials when the patient's significant percentage have to reduce the dose, have to stop treatment. That is a serious issue. So I do think in the era of precision medicine and personalized care, we really should be tailoring our treatment to specific pathways, not one-size-fits-all approach.
Absolutely. All right. Thank you very much. Let's do the second video.
Dr. Sunil Gandhi has a patient with a BRCA germline mutation and metastatic prostate cancer, but also with an unfortunate complication of treatment.
This 74-year gentleman, very, very smart individual, prostate cancer, BRCA2 positive, mother had ovarian cancer in 40s, started on LHRH agonist and abiraterone. 3 months, some response, but PSA progressed right away. So we gave docetaxel, disease progression. We started on olaparib. He responded, PSA came down from 200 to 100, and pain has gone away. Issue on him is he's getting a lot of neutropenia. He required 3 units of blood transfusion, 1 neutropenic fever admission. Like 10 minutes before I came on the conference, I got a phone call that he is now admitted with 2nd neutropenic fever. And he has pulmonary embolism. He may need intubation soon. What do we do? Is low-dose olaparib equally effective or not in BRCA2 positive disease? But next patient I should give olaparib and abiraterone. I want some discussion on that too, if I can hear it.
So in summary, Dr. Gandhi would appreciate input on management of cytopenias seen with PARP inhibitors and the question of whether lower dose therapy, such as lower dose olaparib, is equally effective or not in BRCA-positive disease. Also, whether or not the combination of a novel anti-androgen strategy with a PARP inhibitor is of greater value, for example, the use of olaparib and abiraterone.
Dr. Smith?
Yeah, so it's good case, a lot of interesting issues. So PARP inhibitors have toxicities, including hematologic toxicity. Some of these patients can be successfully managed with dose reduction. This sounds a bit more problematic because if I understood what was said, he had pulmonary emboli and was intubated. Is that what was said?
Talking about intubation, it sounded like.
Yeah, so that doesn't sound great. But like if we set that issue aside, if it was a non-starter that the patient simply couldn't tolerate a PARP inhibitor but had responded, then there'd be consideration of treatment with platinum. But I think for a more typical patient with issues of particularly anemia, you can get through that with dose reductions, and we've had some durable responders with BRCA mutations who had initial problems with anemia who do quite well with dose reductions.
I'll say, as oral daily therapies with multiple pills, I find titrating PARP inhibitors to actually be quite easy, right? I mean, you can really optimize quite a bit in this population. I've had multiple 90-year-olds on PARP inhibitors, and I never start them at full dose. I always start them at 50%. And you can almost always find a tolerable dose for an individual patient with titration. It's just very convenient in that sense. What about the question, we've already touched on this some, Dr. Antonarakis, in the last minute here then, how do you see the combinations of NHAs and PARPs?
Well, this was an easy one because he was a BRCA2 carrier, and I think I heard he was a germline carrier too, so he probably has a biallelic inactivation, we don't know. So in this patient, assuming he received ADT up front or ADT plus docetaxel and not abiraterone or enzalutamide, I would give combination.
Yeah, fair enough.
Agreed. Actually, I have a gentleman right now who was diagnosed with prostate cancer at age 48, progressed, was de novo metastatic disease at 48, developed castration-resistant disease after a year of treatment, has been on a combo, Abi and olaparib, for 5 years now, in remission.
Yeah.
I mean, it can be dramatic. I mean, this is an extreme case, but it can be dramatic with the BRCA2.
Now, at some point, do you hold the PARP? Do you keep going? You're going to get myelosuppression, marrow ablation?
He's tolerating it, Don't mess it up. That's the critical
don't mess
part.
with success.
Don't mess
I
it
hear
up.
you. I hear you. All right, very good. We'll move on to our next talk then. Dr. Antonarakis.
Okay, I'm going to cover a few things here. First is the incidence of homologous recombination gene mutations and the indications for testing. And I want everyone to leave this seminar continuing to test as often as you were before and not less. So if you take a tumor sample from a metastatic prostate cancer patient, you'll find a homologous recombination mutation in about a quarter, about 25%. And if you take a germline sample, usually saliva or blood, you'll find mutation in 12%. So the one way to think about it is, in the tumor, the HRR mutations, half of those will actually be from the germline. So half of the somatic ones are, in fact, derived from the germline. The indications for testing have gotten complicated, and I've summarized them here in this not so straightforward table. The left is the germline testing, basically everyone with metastatic disease, everyone with high-risk localized disease, and then some patients with intermediate risk or low-risk localized disease, depending on other family histories of cancer. Somatic testing is really restricted at this time to anyone with metastatic disease. It can be considered in people that have pelvic nodal disease, but of course, the main reason for that is the PARP inhibitors and the PD-1 inhibitors in the case of mismatch repair deficiency. And thank you, Matthew, for going through some of these slides for me. I can save some time. These drugs work on this concept of synthetic lethality, which means that in the context of a BRCA or related mutation, these drugs will cause DNA damage, which is not repaired by the cell. But without the presence of these mutations, the drugs are not working at all. And these are the 4 that have been tested in prostate cancer. They're not all the same, as was mentioned. They have different abilities to inhibit PARP1 and PARP2, and they have different capabilities of trapping the PARP protein on the DNA, which can result in catastrophic DNA damage during the DNA replication process. So as you can see there, talazoparib, for example, is the strongest PARP trapper, as well as potentially the strongest PARP1 enzymatic inhibitor. Please take a photograph of this if you wish, because I'm not going to go through all of it. These are the monotherapy studies. If you look at the right-hand column, the objective or PSA response rates in the biomarker positive patients are between 30 and 50%. That's the punchline. And let's review some of the pivotal studies for monotherapy, and then we'll review the studies for combination therapy. So this was Maha study with Johan de Bono. The ATM BRCA1, BRCA2 cohort was the primary analysis, and then there was a secondary cohort B with 12 other genes. And in each case, the physician chose Abi or Enza versus olaparib. And this trial was positive both in the cohort A, which is not shown here, and in the entire population of patients when you combined cohort A plus B together into one analysis. And because of the primary endpoint being met in the entire population of patients with 14 genes, not just the 3 genes, in this country, the FDA approved olaparib as a monotherapy for a panel of 14 genes, including BRCA1, BRCA2, and ATM, but also several others. The genes do not all behave equally. BRCA2 is associated with the greatest benefit, as was mentioned, while other genes are associated with more modest benefit. So the monotherapy indication for olaparib in prostate cancer, which is almost now 3 years old, I can't believe it, is for people that have received at least one novel hormone therapy, pre or post taxane chemotherapy, so the taxane is not mandatory, and they have a germline or somatic mutation in one of the 14 genes shown in the small print at the bottom, and BRCA1 and BRCA2 is in that list. And then we have the development of rucaparib, the phase 2 program called Triton-2, which was a third-line population of post-AR and post-taxane chemotherapy, and the Triton-3, which was presented today and at PCF as well, led by our moderator, Dr. Bryce. Triton-2, this was a study looking at objective response rate, unusual trial because patients had to have measurable disease to enroll, which is the minority of our mCRPC patients, but the waterfall plot shows the BRCA1 and BRCA2 patients only, about a 44% response rate there. But if you look at the other genes on the top table, you can see very underwhelming responses or lack of in the other genes. And because of that, the manufacturer decided to only file for accelerated approval with the BRCA1 and BRCA2 population alone. Now, this may be extended with the results of the Triton-3 study, which I'll show in a second. So the third gene that may be added to the FDA approval, although it's not currently the case yet, might be ATM. And we all have our different ways of showing the trial design. I'm glad that we're not duplicating slides, but this is Triton-3 study. So 3 genes were included in the eligibility, BRCA1, BRCA2, or ATM. So ATM snuck back in. And here we have a pre-taxane population in mCRPC, so they couldn't have received a taxane in mCRPC. And patients were randomized 2-to-1 to rucaparib, 600 milligrams twice daily, or physician choice, which for the first time and importantly included a taxane docetaxel. Now, I apologize, Alan, I have not updated my slides because I made these last week, but I did have these slides from your PCF presentation. So this is the intention to treat population, radiographic progression-free survival, primary endpoint. Nobody would argue with that. But what I found interesting, and this was presented very transparently at the PCF, is that the benefit in ATM, in my opinion, is really not there. That's my personal opinion. But in the BRCA1-2 subset, it's impressive. And we saw updated analysis today comparing the PARP inhibitor to the taxane group separately and to the AR group separately, and the benefit is maintained, again, primarily driven by the BRCA1 and BRCA2 patients. Now, these are the 3 trials that are hopefully not confusing us too much. PROPEL, which we've seen many times, I'm going to go quickly because Matthew went through this. Biomarker unselected population. The biomarker was done in an exploratory post hoc fashion, but the intention to treat here was in the all-comer population, and the primary endpoint was met. Magnitude was different. It had a specific biomarker positive and a separate biomarker negative population. The biomarker negative was closed for futility. The biomarker positive population showed an RPFS benefit both in the overall HRR group and greater benefit in the BRCA1/2 group specifically. So this one, niraparib plus abiraterone, is not going to be an option for the unselected or biomarker negative population. And the tiebreaker, TELAPRO-2, this had two components, an all-comers cohort 1, which was presented today, and a second cohort, cohort 2, which is the DNA damage response alterations, which is still maturing and was not presented today. So this is important. Part of the trial was presented, but not the complete trial. And again, I made these slides prior to Niraj's presentation, so I didn't have the Kaplan-Meier curves. But what you can see, number one, is in the all-comer biomarker agnostic population, there is a benefit with 0.63 hazard ratio for RPFS. And then if you cast your eye down to the HRR mutated, you see that the hazard ratio becomes more impressive, 0.46. But again, even in the known wild-type homologous recombination patients, there was a benefit with an upper limit of the hazard ratio of 0.91, again suggesting in this trial that both the overall population and each of the biomarker positive and negative subsets may benefit in terms of at least RPFS. So in conclusion, germline and somatic mutations in homologous recombination genes are common, and we should continue to test for these moving forward. Olaparib as a monotherapy is approved for a panel of 14 genes. Rucaparib currently at this time is approved for BRCA1 and BRCA2 mutated patients who have also received a taxane chemotherapy, not just an AR therapy. We've got PROPEL and Magnitude showing apparently discordant results where PROPEL showed a RPFS benefit in the unselected population, which was even larger in the biomarker positive group, while Magnitude didn't show any benefit in the unselected group and only showed a benefit in the HRR positive group and even greater in the BRCA1/2. And then the tiebreaker TELAPRO-2 with results more consistent with the PROPEL showing both in the unselected all-comer population and in the HRR positive and negative groups a potential benefit. I do want to point out in this country, no PARP inhibitor-based combination is currently FDA approved, so while many of us have done that in our clinics, that is currently off-label use, although the European Medicines Agency, EMA, has approved olaparib plus abiraterone, surprisingly to me, in unselected patient population in the European continent. Thank you.
Very good, thank you. All right, we do have an audience question, or several, but let's try to get to at least some of them. Emmanuel, how about variant allele frequency? How does that influence your decision to try PARP inhibition in patients with qualifying mutations?
So the more that the cancer cells possess the variant, in theory, the greater the benefit. This becomes challenging when you have circulating tumor DNA because you have contamination from other DNA sources, so you get, in general, much more diluted and lower variant allele frequencies. But the higher the better. And if you ever see a variant allele frequency in any sample, whether it's a tumor or circulating tumor DNA that's above 50%, then you can infer that this is a germline mutation plus a somatic loss of heterozygosity. So the cases that you should get the most excited about are the ones where you see variant allele frequencies of BRCA2 in the 70 to 80% range.
Yeah. All right, very good. Let's get into a video.
Dr. Vignesh Narayanan as an 85-year-old man with metastatic castrate-resistant prostate cancer and disease progression after 5 lines of treatment.
The trouble with this gentleman was, even though he was quite robust, he was just blowing through every regimen. He started developing very rapidly symptomatic disease, just developed severe asthenia, weight loss, abdominal pain, nausea. And we got a PSMA PET recently that showed extensive burden of metastasis in the liver, as well as in the bones. These had all progressed significantly compared to his previous CT scans as well. Biopsied the liver and found that he had had small cell transformation in addition to some adenocarcinoma features as well. So the questions on this patient really were what the ideal treatment for small cell transformation of prostate adenocarcinoma might be. We were considering, well, would this patient be a candidate for lutetium PSMA, but with such widespread metastatic or visceral disease, would he be a candidate for that? I mean, assuming there were no small cell features.
Even with the small cell features, it's interesting that he's picking up PSMA.
Yeah, I mean, I think he had adenocarcinoma with small cell features, so I don't think he had, maybe we caught it fairly early in the transformative phase, perhaps.
So the question here is whether lutetium might benefit a patient with at least partially transformed or mixed small cell histology that remains PSMA avid.
Dr. Fizazi?
Another super tough question. Approximately 20% of all the patients who have advanced prostate cancer will develop indeed a neuroendocrine transformation, a differentiation. It's complex disease, much more complex than we thought initially. It's not only liver disease and not PSA expressing disease, etc. It can be much more subtle. The issue is that, honestly, we don't know how to treat these men, ideally. At least I don't know. My main recommendation is, when you're facing one, just be cautious. Try your best with your option, but reassess it as soon as possible so that you have the opportunity to switch to something else if the patient is not responding. The efficacy of carboplatin and etoposide is actually not that fantastic in this space. We looked at that in our experience. Approximately 25% of patients respond, which is not zero, obviously, but nothing really fantastic. There's been some tried within trials to target various proteins, but it didn't really work. So honestly, I think we just don't know how best to treat these men. It's not just because there is a neuroendocrine transformation that the current drug will not work. Some patients do benefit from taxanes, for example. Some patients, as I said, will benefit from carboplatin. We don't know much about lutetium PSMA, at least I don't. I'd be curious to hear again colleagues on that. But this really remains the subgroup which remains super hard to treat.
Dr. Hussain, how about the other two questions? Available clues on liquid biopsy and then role for lutetium if there's evidence of PSMA uptake.
I think that the minute you have a transformation to a small cell carcinoma, that becomes the very end stage of the disease. And so I don't know that I would really go by the clues on liquid biopsy, to be honest with you. And I've had many of these types of cases, including several that I'm treating right now. I generally would go into chemotherapy for small cell. And again, I have like 2 of them that I'm treating right now. They've completed the 6 cycles, and I usually apply the same principles of small cell of the lung with IO afterwards, and then hope things will move. I agree with Karim. I don't really know that we know about the data with lutetium in this situation, but at this point, you're going to have to balance risk and benefit, and the faster potential killer is going to be the small cell.
Yeah, absolutely. All right, let's go on to our next case.
Dr. David Morris has a 76-year-old man with metastatic castrate-sensitive prostate cancer receiving his care as part of an important study.
He elected a clinical trial with enzalutamide with a plus or minus of a PD-1 inhibitor for metastatic castration-sensitive disease.
Well, that's interesting. Any autoimmune problems?
We have over 10 people in a PD-1 trial in this disease setting, and we're having a hard time figuring out, based off the placebo dosing, who's getting the PD-1 and who is not.
Wow.
So I guess that's good news.
Any other questions?
I'd love for the faculty's input on oligometastatic disease. We've had a bunch of patients who presented with early PSA recurrences and have now, with the newer PET imaging, found to have 1 or 2 nodes here or there. and we've sent them for radiation oncology evaluation for potential SABR therapy to metastatic lesions.
So in addition to your thoughts on ongoing interesting clinical trials, including immunotherapy studies, Dr. Mars is interested in your use of local treatment for oligometastatic disease.
So Dr. Smith, do you want to comment on IO therapy checkpoint inhibitors in prostate cancer?
Yeah, I think they have a very important role in patients who are MSI high or dMMR, right? And so that's part of the reason to do tumor genetic testing. It's very gratifying to treat such patients. Some of them have durable, deep responses, and a few, probably everyone on the stage here has some patients who appear to be cured by IO. So that's a reason to look for it. For the rest, for the majority of for everybody else, not so much. I mean, I think there are a number of ongoing studies, but we have a long way to go, and they're not part of standard of care in any other context at this point in time.
Yeah, fair enough. And then do you want to comment on your management of oligometastatic disease? When are you thinking about local therapy?
Yeah, so this is not a new issue, right? It's just that better imaging makes it a more common issue. Yeah. And when you find it, boy, it is tempting to treat it, but I don't think we know exactly what we're doing, and I'm very careful when we take that approach with patients to advise them that we have to assume that there are sites that are just below the threshold of detection, even by sensitive testing like PSMA PET CT. So we try to really look deeply at the clinical context, interval from primary treatment, tempo of the disease, intensity of the identified sites of disease. So, if you find 2-3 millimeter PSMA avid lesions, shortly after primary treatment, I'd be hard pressed to believe that those are the only sites of disease, for example.
Yeah. Dr. Antonarakis, how about Minnesota? What are you doing with oligomet?
Well, this one was metachronous, so that's important. It's not synchronous. And the time interval between radical therapy and the oligomets is important. If it's more than 5 years and the mets are 3 or fewer, I'm tempted to treat them with SBRT plus a short and finite course of ADT or ADT plus abiraterone with the intention of stopping.
This is a related question from the audience. So, Dr. Fizazi, where are we with the use of IO in MSI high oligometastatic mHSPC with Gleason 9 disease?
Well, first, MSI high are very rare, approximately 2% of all the patients. So if I take all those parameters, it's hard to address the question. I guess most evidence we saw was for mCRPC. And indeed, if we detect an MSI high phenotype in these gentlemen, I agree with what was said. We should do our best to treat them with an IO. We do see durable responses in these men. Now, if this is being detected in a metastatic castration-sensitive disease situation, I really don't know whether we should incorporate the IO upfront, assuming this is possible in terms of approval/reimbursement. I think it's probably reasonable to wait for castration-resistant disease, but honestly, I don't know.
Yeah, no, very fair. All right, and there's a couple of variations on this question from the audience, but the desire to avoid LHRH therapy, right? The desire to avoid testosterone suppression. Would you consider anti-androgen monotherapy in select patients with metastatic disease or other strategies to avoid testosterone suppression?
I do that in basically two situations. One is a gentleman who clearly says no about castration after I have explained the pros and cons. It's rare, but it happens, obviously mostly for sexual reasons. And in those scenarios, I tend to tell these patients that we have data with single-agent bicalutamide 150 showing that there is clear efficacy, although in a randomized trial with approximately 800 men, if I recall it well, castration actually did better by overall survival. So really the discussion is, yes, we can do that, and this will probably maintain your sexual life better, but yes, also, at least statistically speaking, you will perhaps live shorter time. And I think this has to be clearly explained. Now, whether we can use also a second generation AR inhibitors such as apalutamide, enzalutamide, or darolutamide, we don't really know. The experience so far has been from phase 2 trials, so it's hard to say. The second situation is perhaps a man with very strong cardiac comorbidities. Even with the LHRH antagonist, it's not a disease. Someone who had a myocardial infarction, say, a month ago, and on top of that, he has terrible metastatic prostate cancer. What to do? Hard to say. And again, in those situations, sometimes I've been advising single agent bicalutamide for the same reasons, but honestly, I don't know whether I'm right or not advising that.
Fair enough. All right, very good. Now we will get into our last presentation then. Dr. Fizazi.
Oh, I thought you asked me to speak about my last vacation, but finally it's a different title. Okay, I'll try to do my best. So this is supposed about what's next when you have exhausted the treatment my colleagues just reported to you with clear evidence of overall survival benefits. So second, third, fourth mCRPC lines. So first, we have evidence about radium, and this came from a randomized trial reported now a decade ago, believe it or not, showing overall survival. So this is a bone targeting agent because radium goes to the bone. The bone thinks it's calcium, but out of a sudden it's radium, so you are irradiating the disease where it is. Obviously, if patient has bone metastasis and if this is predominant. So overall survival was shown to be improved in this situation, and this came together with a quite reasonable pattern of safety. Thrombocytopenia was there, a slight diarrhea, but honestly, not too much of a toxicity with this treatment. So this is something you can also use in the elderly. The issue, though, is that we don't really know whether we should still use radium, because again, as I said, this was shown a decade ago, and we haven't seen any other randomized phase 3 trials with positive readouts. We know from Dr. Smith's trial combining radium with abiraterone that actually we should not do it because there is a clear excess in fractures. But really whether radium works when abiraterone and enzalutamide, these drugs have been used, is really unknown. And this is why we're currently conducting the RADIANT trial, which is rapidly maturing now. We have almost completed the atrial. So hopefully this trial will better positionate radium in the current armamentarium. Cabazitaxel is another obvious option. We now have data from CARD, clearly indicating that cabazitaxel is a very serious candidate in the situation of third line, fourth line, whatever. And CARD really was a pragmatic trial, focusing on men with mCRPC who had exhausted one AR drug and one taxane. And the question was really, should we go for the second taxane or for the second AR drug? So cabazitaxel or ABI or ENZA, depending on what the patient had received in the first place. And the answer is clear, cabazitaxel wins. Against ABI or ENZA, don't think too much about that. Cabazitaxel is really the winner. So I think we should keep using cabazitaxel. I do use it quite a lot in my practice, especially now that we have data indicating that 20 milligrams is, pretty much as active as 25 milligrams. And I also do it with GCSF support, starting from the first cycle. And for these men, most of these men, honestly, 20 milligrams and GCSF makes it a quite friendly chemotherapy regimen, I have to say. But maybe important also is a recent report from the capacity trial indicating that for frail patients, you can even use lower dose of chemotherapy with cabazitaxel 16 milligram per square meter, used every 2 weeks or so. And actually this works pretty much the same as compared to cabazitaxel 25 milligrams every 3 weeks with much less toxicity. So in frail patients, I actually do use cabazitaxel 15 or 16, which is pretty much the same, obviously, with GCSF support. And you may consider just using a higher dose after one cycle. But really, cabazitaxel remains a key player. There are actually data reported at this Congress regarding the microenvironment and cabazitaxel. I will not have time to comment much on that. PSMA lutein is obviously a very important player. PSMA is overexpressed by many prostate cancer, we all know that. And VISION is a positive phase 3 trial showing clear overall survival benefit on top of RPFS benefit over the best options, or what was thought to be the best option in the control arm. As we already alluded to, there are data supporting the use of radium and then lutetium PSMA sequentially, and if anything, actually these patients did well as compared to patients who had not received radium prior to that. So we're not sure about the exact sequence, but at least this is reassuring. Now we're waiting for more data about PSMA lutetium. PSMA addition is testing whether we should use lutetium PSMA in men with metastatic castration-sensitive disease. It's currently enrolling patients. And in the center of the slide, you see 2 trials, PSMA-4 and SPLASH, which are looking at the same hypothesis, which is whether PSMA lutetium can also help patients with mCRPC who have not been treated with chemotherapy. I believe these 2 trials have completed their accrual and they should report anytime soon. We saw a press release about PSMA-4 indicating that it's a positive trial. So we'll see in future trials the data. And this is actually the press release that came out right before Christmas. Very important also in this manner, I would like to take my time on that, is that we should not forget about using burn-targeting agents such as denosumab or zoledronic acid. This data that I'm now showing on the screen comes from an early analysis of a P3 trial, which is combining enzalutamide with or without radium-223. And when the data from the ERA-223 trial with abiraterone and radium came out, suggesting or indicating clearly that there was an excess of fracture with abiraterone, but most importantly with the combo, the investigators or the chair from the P3 trial amended the trial to make denosumab or zoledronic acid mandatory in all next patients to be enrolled in the trial. And what they did and what you actually show in this slide is an analysis of what happened in terms of fracture incidence before and after this amendment. So in blue is the curve of fracture for men receiving enzalutamide plus radium. And as you can see, this is really bad. At 2 years' time, approximately half of the patients have developed at least one fracture. Terrible. Now, in green is the same for enzalutamide, again without burn-targeting agents, and it's not good. approximately 20-25% of men develop a fracture by 2 years' time. Now, if you look at the red curve and black curve, it's exactly the same treatments, enza with or without radium, but now with denosumab prevention. And actually, denosumab prevention works with almost no detectable fractures in these men. So I think besides what the Peace 3 trials will eventually report, I think this is key for the practice today. We should use bone-targeting agents when using abiraterone, enzalutamide, and probably taxane as well in patients with bone disease and CRPC. New options, I'll be fast, but I think we have exciting stuff coming. Cabozantinib and atezo reported some promising data, but honestly, I'm not sure this is really different as compared to what you would expect to cabozantinib alone. I'm not necessarily convinced by the combination, but we'll see. Phase 3 trial is maturing, and this is the design. We spoke about that earlier, so I'll be rapid. This is the wild-type AR with androgen stimulating this, but this is now a mutation, 702. Corticosteroid can actually take the place of androgen and stimulate this mutated version. This is the 878. We saw this happening in a case. Progesterone can actually bind to this mutated AR. As I said orally earlier, we've been trying to address this question with a drug, ODM-208, which really prevents the making of all steroid hormones. So we have to supplement these men, of course, with mineralosteroids and corticosteroids, otherwise they would probably die. So, but the good news is that this combo, ODM-208 with this implementation, is active. And I think we have a biomarker. You will see to the right-hand side of the slide the efficacy that was detected in the phase 1 part in men with AR mutation. Almost all of them derived efficacy, although they had already exhausted all existing treatments. And this was actually subsequently confirmed in a phase 2 expansion part. You see the degree of efficacy is very high, with durability also seen. Last but not least, probably, I think we have a new candidate for immunotherapy, and this is B7H3 targeting with an ADC. B7H3 is a checkpoint similar or different, obviously, to PD-1, PD-L1. We don't know exactly what it does in the physiology, but we can actually target that with B7H3. And it seems to be really active. So more data is obviously coming, but I think this is really promising. So we have, I think now, examples of biomarker-triggered efficacy in mCRPC. We spoke about BRCA with PARP inhibitor. We spoke about MSI-high, PD-1 inhibitor, PSMA expressing cancers, PSMA luteation, and I think more is coming. PTEN loss and AKT inhibitor, not necessarily the first generation. AR mutation and ligand inhibitors, I just spoke about it. CDK12 and PD-1 inhibitors, less than MSI-high, but still, make sure you give it a try. And probably more will come in the coming years. Thank you very much.
All right, that's the end of our presentation tonight. Thank you, everyone, for your time. Thank you to the panelists for your presentations and the conversation. And thank you to our community physicians who provided the cases. Have a good evening.